I'm Christy Schumacher, the chair of the Education Committee and chair-elect of the AmCare PRN. So today we're going to talk to you about the nuts and bolts to billing and reimbursement for pharmacist services. And today we have with us Dr. Ryan Wargo and Dr. Megan Wesling. So Dr. Wargo is an ambulatory care clinical pharmacist and the ambulatory pharmacy manager at Legacy Health in Portland, Oregon. As a manager, he's responsible for operational, financial, and quality performance goals for pharmacist services within ambulatory care clinics and population health. So welcome, Dr. Ryan Wargo. And we also have Dr. Megan Wesling. So Dr. Wesling is an assistant professor at the University of North Texas Health Science Center, College of Pharmacy. She also serves as the ambulatory care pharmacy director and clinical pharmacist at HSC Health in Fort Worth, Texas. She works in an interprofessional team to operationalize billing models for pharmacist services and support quality care in a medically complex patient population. So thank you, Dr. Ryan Wargo and Megan Wesling, for joining us today and sharing your expertise.
Thank you so much, Christy, for the introduction. Dr. Wargo and I are really excited to have the opportunity today to lay the foundation for billing basics. We do want to give you an idea of some other opportunities that will be available via topic roundtables in outpatient physician-based billing, billing opportunities for telehealth services, and those services that may be conducted within a federally qualified health center. Here later in the summer months, we're fortunate to have experts scheduled in each area to offer about an hour of discussion, an opportunity to ask questions and elicit service and solutions, elicit advice and solutions to barriers or issues faced in optimizing your pharmacy services there in the practice setting. With this in mind, we'll go ahead and jump into our billing basic learning objectives, which we hope to achieve the following in our time together. We're going to discuss relevant history and billing terminology pertinent to the development of pharmacist-directed clinical services. We're going to identify relevant stakeholders that will support such services in their implementation and operationalization, and also describe available billing and reimbursement models that support such services. We want to first kick off our discussion today with defining who to engage and have on your team from your institution when discussing relevant billing mechanisms for your desired service. The listed individuals here on this slide will help establish expectations on the service, help you in the implementation of billing mechanisms into clinic workflow, and support logistical integration and assessment of the service operations. I particularly want to call out 3 team members, with the first being your institution or organization's compliance officer, who will serve to ensure your services are complying with the laws established and help you identify and prevent erroneous and fraudulent claims. They'll also eliminate billing mistakes and reduce the chance of you being audited for the billable services. They also will ensure that you stay informed of changes to billing rules and regulations, as you'll find that they are constantly modified, and it does become a little bit difficult to keep up. So with that, you'll have your compliance officer available to support you in those endeavors. And you'll also work closely with the billing department leader, or you may also have this person referred to within your institution as your revenue cycle leader or revenue cycle director, who will provide you with the expertise to identify patient reimbursement issues that may come along. They'll help to ensure that claims, denials, and appeals are also efficiently processed. This individual will also provide guidance on not only the implementation of the services and the billing mechanisms desired, but also be a resource to you for feedback on adjustments that may need to be applied in the billing practices for you to ensure successful reimbursement. And lastly, your health informatics analyst, who will serve in the capacity to collect and interpret data related to your efforts of the pharmacist and the effectiveness of your service. This will also further support the process of quality improvement related to the service that you've developed. So now that we've discussed and described who to have on your team, we want to provide a review of foundational concepts and common terminology that will serve to support conversations with your stakeholders in the implementation and functional phases of your billing and reimbursement. So we'll start out by discussing state rules and regulations. And when you're pursuing implementing direct patient care services and considering billable mechanisms for such services, you need to understand what actions and processes that you as a pharmacist are permitted to perform. These actions will be defined within your individual state scope of practice laws, and we encourage you to review those ahead of any initiation of those billing mechanisms. Every state scope of practice will have a little bit of different language, despite us all being drug experts and trained in the safety and effectiveness of medication use. It is only those described actions that will support eligibility of billable services to your public and private payers. If there is an action that is not described within your state scope of practice, then this may not be rendered and subsequently reimbursed. In addition to understanding your state scope of practice laws, a collaborative practice will further provide a mechanism for you to advance and operationalize your scope of practice. A collaborative practice agreement will serve as a formal yet voluntary agreement entered between a provider, so maybe a physician or a nurse practitioner or a PA where allowed by the state laws, and that pharmacist that describes the specific patient care functions delegated to that pharmacist. This may include authorizing prescriptive authority within your institution. It could include initiating, adjusting, or discontinuing medications. It could be allowing you to order or monitor labs or diagnostic studies. So these privileges delegated to that AmCare pharmacist will vary by state, practice site, and payer. So we encourage you to go back to those state rules and regulations to define within what parameters you may function. One thing to note is that some states will provide you provider status, and this CPA may further support those contractual opportunities to generate revenue for pharmacist patient care services. If the state provider status or the insurance code rules and regulations are limited, we find that the billing and reimbursement opportunities will fall back on the rules and regulations set out by the Center for Medicare and Medicaid, or CMS, who ultimately serve as kind of practice standard. Unfortunately, per CMS, we as pharmacists are not presently recognized as qualified billing practitioners, but rather get identified as auxiliary personnel or auxiliary staff, maybe sometimes clinical staff. And with this designation per CMS, most pharmacists will not be able to directly bill for the services rendered, but be claimed through unique rules that we'll discuss in the coming slides. Now, given that CMS really serves to standardize billing and coding rules and the regulations for the majority of healthcare payment models, we must understand how they're put in effect. So CMS actually delegates to Medicare administrative contractors who serve to operationalize these Medicare fee-for-service programs. And you may recall fee-for-service describes the unbundled program that pays for healthcare services rendered. It's more defined by quantity. So I do a service, I get paid for that service. You may see that we're changing a little bit in healthcare to more quality-based care. And that is a different and separate conversation that we won't have an opportunity to discuss here, but I want to make sure we have the foundation for fee-for-service. Now, MACs are multi-state, they're regional contractors with various responsibilities. And these responsibilities include the administration of Medicare funds to the providers. They'll also provide oversight on processed claims, medical coverage review. They'll respond to provider inquiries or be a source for education. And they'll also establish local coverage determinants. So as of December 2020, CMS divides the country into 12 regions, each with its own contracted MAC. So you can look within your region and identify who your MAC provider may be. In the state of Texas, we work with Navitas. And the reason I'm notating this is that it's valuable for you to identify your region's MAC provider at the beginning of your service development, as they have been notorious for establishing individual interpretations to Medicare billing laws. So these interpretations may influence the services that may be billed by a pharmacist. So now we've traversed the regional and state terms. I want us to talk a little bit about pertinent terms found within your individual institution. Many of these terms will come up into conversation with your varying stakeholders, and it'll be important for you to understand them and how they may influence your clinical service defined. So in addition to compliance of laws and regulations governing the billing mechanisms that you're employing, credentialing and privileging will support enhanced pharmacist authority within the institution. So credentialing is defined by verifying and making assessment on what individual qualifications and what that individual's qualifications can provide within the institution, while the privileging process authorizes that individual to perform a specific scope of care within the facility. Furthermore, you want to discuss and understand the payers engaged within your institution and its payer mix, as this will help determine your potential revenue. This will define the services you can incorporate into your setting. It'll define your eligibility to provide these services based on your state scope of practice and your ability to meet the requirements of the billing code sought. So for example, in my institution, my payer mix is largely state Medicaid and Medicare, with a very small portion of our payers being in the commercial or other healthcare payer group, so self-care or workers' comp. With that being the case, and my payer mix being largely Medicare and Medicaid, that really drives me to look at more of the CMS rules and regulations. Whereas if I'm looking at commercial payers, we could have discussions on where pharmacists can otherwise be integrated. Now, in addition to understanding your institutional terms, we also need to define the various providers and personnel that will be a part of the claims process for the billed service. So this is kind of pertinent to the back end of medical billing, when the billing and coding department is going to submit your claims. And sometimes those claims will require description of the provider information itself. So based on the service that you're engaging in, the claim may require description of the billing provider or the person who is registered and is allowed to bill the services rendered to the payer. However, this person may not be the same person who rendered or provided the service. That person would be identified as the rendering or the service provider. As I mentioned earlier, CMS describes pharmacists as auxiliary personnel. This definition as auxiliary personnel can define what actions we can take within our clinical service and also put you in a position of being the rendering provider for the services performed. In many cases of pharmacist-directed clinical services, there's often a requirement for a formal referral process or enrollment process to be in place for you to enact or trigger the pharmacist's involvement in that patient's direct care. So in this case, we would describe this as our referring provider, the person who directed the patient to us for care. And then finally, you'll hear us discuss on various slides to follow that many of the eligible clinical services by pharmacists require some type of supervision upon the performance of that billable service. And that supervision has to be documented and linked to the supervising provider. Now, the supervising provider most often will be a physician, but they could be another non-physician qualified healthcare provider, such as a PA or an NP. And I'll direct you back to the federal and state laws to define who that other non-physician qualified healthcare provider may be. Now, understanding the personnel matrix and the related association to billing and reimbursement rules will further support accurate and successful implementation of your billable clinical service. And as I referenced, I want to dive into a little bit about type of supervision, because as I stated, many of our billing and reimbursement models that we'll discuss do require a specific supervision to be met. in order for us to maintain compliance with the rules and regulations at the time of the services being rendered. And there's two main types of supervision that I want us to kind of talk through. The first is our general supervision. So this is the services being furnished are at the overall direction of your physician, but the physician's presence is not required during the performance of that service. There's no requirement for that supervising provider to be in the same physical space. However, like I stated before, there must be evidence of the supervision through sharing of a plan of care or sufficient supervisory communication between the two. While direct supervision would be met by the physician being present in the office suite and immediately available for assistance and direction throughout the performance of the service. Now, I'm notating a difference in what that would look like in the hospital outpatient setting, where the supervising provider is present on campus where services are provided, or present within the office, within the off-campus department. Notably, I do want to state that in a group practice, your eligible providers may cross-cover for one another and still maintain adherence to the supervision requirements. It does not have to be the same person that referred the patient to you. So before we jump into a couple of other terms, I want us to kind of put some of these definitions into action. So we have a little vignette here, Mr. Gage, who's coming to pharmacy clinic with Dr. Wargo for diabetes medication management at the referral of Dr. Long, who is Mr. Gage's patient primary care physician. It's Tuesday morning and Dr. Long is at the hospital for rounds, but Dr. Patel is on site at the clinic today conducting direct patient care. Now, I want to note specifically where we are right now. So right now we are in an outpatient office-based clinic that is not associated with a hospital. So we'll go ahead and categorize the personnel into their respective terms. So based on those provider and personnel definitions, Dr. Patel would not only be the billing provider, but also our supervising provider, as he is on site and accessible at the time of service when Dr. Wargo is performing his clinical care. Given this CMS definition, Dr. Wargo as the clinical pharmacist will not only be recognized as the rendering provider, but also as our auxiliary personnel. However, neither Dr. Patel or Dr. Wargo will be recognized as the referring provider, as Dr. Long, Mr. Gage's PCP, referred the patient to Dr. Wargo. I do want to note what this would look like if we were in a hospital setting. So in that respect to the supervision rules, Dr. Long may have qualified as not only the billing provider and the supervising provider at that time if we are meeting the locale and logistics of the location in which services are provided. In this experience here, we're specifically noting an outpatient office-based care where Dr. Long is not eligible since he is not immediately accessible. So now that we've identified provider information with respect to who did the service, now we have to describe a couple of other things. And that includes description of the service itself, why it was done, and how much the service is worth. And this is all detailed as part of the billing process and the claim submission process done on the backside with your billing and coding department. Now, these functions may be described by your healthcare common procedural coding system, or for short, HCPC codes, your international classification of disease 10th revision, or your ICD-10 codes, pending update in 2022 to ICD-11 codes, and then your relative value units, respectively. So as we move through the rest of our presentation today, we're going to refer to HCPC coding systems that will describe the services conducted by the pharmacist. However, I want to provide a little bit more detail on this procedure coding system for us before we progress. So presently there's two levels, both updated annually, with the first level consisting of the current procedural terminology code set, or for short, CPT codes. These CPT codes are maintained by the American Medical Association, and they're comprised of three categories, with the most often category discussed related to pharmacy-based auxiliary services, found in our category 1. We can see evaluation and management, which Dr. Wargo will go into a little bit more detail about, as well as medication therapy management code sets. CMS does maintain these level 2 codes that are alphanumeric medical procedure codes representing items, supplies, and non-physician services that are not currently covered by the CPT level 1 codes. Pertinent to the pharmacist patient care services, we often see many G code categories, and we find that our diabetes education codes and our chronic care management enrollment codes are fulfilled within this G code set. Now, the value of your HCPCS codes are influenced by resource-based relative value scales, or the related RVU. I'm not going to go into too much detail with that, but if you want to know the fees associated with your HCPCS codes selected, I would encourage you to reference the CMS Physician Fee Schedule website, as you'll be able to find detail for your locale and your facility within that website. Now that we have the fundamental terms in mind, I'm going to turn it over to Dr. Wargo to lead us into billing and reimbursement models that will be considered when establishing pharmacist patient care services. Let me get him some control. You may be muted, Dr. Wargo.
Sorry, Dr. Wesling, but when you gave me control, it didn't give me the option to unmute myself. I apologize for that. Do you mind giving me content again?
Oh, yes.
Now that I'm unmuted. Thanks for bearing with us, everybody.
Technology.
Yeah. All right. So for my portion of the presentation, we're going to begin speaking about billing models commonly seen in ambulatory care. We'll start with incident to billing, as this is perhaps the most commonly seen mechanism for billing and can be a bit more complex. We will mainly be focusing on the elements and definitions of incident to billing rather than coding specifics. While further discussion about specifics does merit further attention, really the purpose of today's presentation is to lay some of that foundational groundwork for understanding the lingo and basic rules. I do also want to reiterate, as mentioned previously, that a lot of the standardization of coding is based off of CMS definitions and standards. So really our focus moving forward will be on those standards. And it's not letting me move the slide. Would you move this forward?
Yeah.
Thank you. So let's first define incident to services. As seen in bullet point 1 here, it's really services that are furnished incident to a physician's professional services when they're an integral, although incidental, part of the physician's personal professional service. I do want to point out that physician really means provider. Dr. Wesling pointed out previously that we do have opportunities to collaborate with a variety of provider types, whether it be a physician, PA, or NP. When billing for incident to services, the visit must be a part of the patient's normal course of treatment, and it must be an established patient in which the provider performed an initial workup. So that is really important. Generally, we think of incident to services as being performed in either a physician office-based location or hospital-based clinic, but they can also be performed in the patient's home. Thank you. In order for providers to bill for incident to services, Medicare does stipulate that 9 requirements must be met. We've chatted about a few of these, and I have some comparisons here, or differences between the physician office-based setting versus the hospital-based clinic. But I do want to highlight a few and maybe dive a little bit deeper. Again, that direct supervision is required. Dr. Wesling did a great job of highlighting the differences in between the differences there between a physician office-based setting and a hospital outpatient-based clinic. But just want to reiterate that, again, that doesn't mean that the provider needs to be in the room with you while conducting the visit. The patient also must first be seen by the physician for evaluation. So although the patient may be new to you, we're not going to be seeing patients that are new to clinic or not established. Very important to ensure that we have a plan of care in place before we're conducting that incident 2 visit. The physician must also have provided authorization for the service in the medical records. So, within our institution, we utilize Epic as our EHR, and we have an order set built for referral to clinical pharmacy services that would, be that authorization for the service. The physician also must continue to see the patient at a frequency that reflects active participation in the management of the course of treatment. So a review of the medical record isn't going to be sufficient here. Oftentimes, people will utilize something called the rule of 3, in which really the intent here is that if you've had a visit with a patient for 3 visits now and has not been back to see their primary care provider or whoever the referring provider was, it may be a good idea to re-engage with that provider to ensure that the plan of care is really moving forward in the way that everybody had intended originally. Also, services provided by the pharmacist incident to the physician must be within the pharmacist's scope of practice as dictated by the state's Pharmacy Practice Act. Really important for you to understand your state's scope of practice rules and regulations, just to make sure everything is according to those rules. And I do want to talk briefly on the next slide about the second to last requirement. So while the financial requirement is not specific to faculty, I do think it's perhaps the one requirement that maybe gets a little extra attention for our practice faculty out there. Medicare states that pharmacists providing the services must be an employee, whether leased or contracted to the provider. And I think this is simple enough, but what may hang some folks up is the requirement for the practice to have some legal control over the person, and for that person to be a representative or have some expense to the practice. To make this a little bit easier to clear this up and to satisfy the requirement, keep in mind that expenses can include salary, but also non-salary support such as exam rooms, office supplies, staff support. So writing this into your contracts between the school and practice institution should help to satisfy that requirement. In regard to evaluation and management, or E&M billing, I think it's really important for us to understand the history of Incident 2 rulings and clarifications as you integrate services into your practice. Here we show a very simple timeline over the last decade, and I think this helps to identify some key communications that would really be worth sharing with that billing and compliance department if needed as you start discussions about billing for Incident 2 services. I think a lot has been cleared up actually here in the last year or two, but it's always worth knowing the history. Until recently, clear distinction regarding allowable billing for services rendered by pharmacists above and beyond the 99211 level had been lacking. To gain some clarity in 2014, AAFP actually wrote a letter to CMS specifically requesting clarification, asking if providers could bill for E&M services at higher levels of service 99212 through 215 if rendered by a pharmacist. And rather quickly, in March of that year, CMS responded saying, sure, go ahead, but remember, as discussed previously, it was up to the regional MACs to interpret that CMS guidance. And with the communication being a rather informal level of communication, it did take some MACs longer than others to accept this interpretation. Much of the ambiguity, I think, though, was cleared up in early 2020 when CMS really explicitly defined pharmacists as auxiliary personnel and stated that services rendered could be billed by the physician NPI or the provider NPI at the appropriate E&M level of service, which was great. But unfortunately, in comes 2021, we came out of the lovely year 2020, and in 2021, CMS updated their E&M billing guidance for the first time in nearly 30 years. And with the update, there was some reversal of the changes and stated that billing for services rendered by auxiliary staff could not exceed the 99211 level. So quite a large downgrade in reimbursement levels for services that oftentimes are at a higher level, close to 214 on average. I personally think there is still some ambiguity in the clarifications from CMS and feel there may be opportunities for pharmacists to collaborate and advocate for allowance to bill at higher levels moving forward. But for now, Medicare is really going to be limited to a 99211 level. This is a great opportunity for us to, though, say thank you to COVID for once. One positive that did come out of COVID has been the adoption of telehealth services. CMS does presently allow for telehealth services to be provided Incident 2, That direct supervision is still a requirement, but CMS has clarified that the supervision can be provided through telehealth or through virtual means, whether with real-time audio and video technology. Keep in mind that our state restrictions, such as scope of practice or licensure requirements, remain in effect. And I highlight the licensure requirements because for those of you that may be practicing in an area where your patient population fluxes depending on the time of year, for example, in northern and southern states where we have snowbirds flocking south in the winter and north in the summer, depending on the location of that patient, if they are not physically located, in a state in which you're licensed, that may be a problem. So do keep that in mind. Also, while we do anticipate some of these changes, or really all of these changes to stay in effect indefinitely, as we come out of the pandemic, that may change. So do be mindful to keep an eye on telehealth services and billing for Incident to services moving forward. Also, with general documentation requirements, there are going to be some changes with telehealth services that you may not see for that typical face-to-face visit. A great opportunity for you to team up with that all-star team we highlighted earlier on in the presentation, just to ensure that you're documenting appropriately. While this isn't a comprehensive list, some things to note. There will be a requirement for consent for telehealth visit from the patient, as well as a statement that the service is actually a billable service. As well as the documentation of the physical location of the patient and you as the provider, as well as the time it takes to conduct the visit. So we're going to stick within the incident to mechanism, but move beyond E&M billing, sort of that traditional billing model that we've seen historically, and talk about something that's maybe a little bit more novel, continuous glucose monitoring. While continuous glucose monitoring has been around for a while, I do think it's still relatively underutilized in a lot of primary care practices, and really a great opportunity for clinical pharmacy services, as there is decent reimbursement, and it's a great patient satisfier as well. CGM can be billed through the incident to mechanism. There are 3 distinct codes associated with CGM as they pertain to the 2 sets of device versus CGM devices. There are both patient-provided and professional office-based provided equipment. The patient-provided equipment is obtained through prescription or through durable medical equipment suppliers and is patient-owned, whereas the professional office-based equipment is basically leased or loaned out to the patient when they come back to the clinic for device download and interpretation. For the 95249 and 95250 codes for the patient and professional equipment respectively, these are really codes for initial training, sensor placement, and initial download and interpretation of at least 72 hours worth of CGM content. Note that for the personal owned equipment, you can only report this code once during the lifetime of the CGM system, whereas for the professional office-owned equipment, this can be captured monthly, but there's no guarantee that it will be reimbursed by the insurance provider. Some commercial plans will. However, for Medicare, the general rule is 6 months. Every 6 months, that this charge can be captured. For the 95251 charge, which is basically for interpretation and reporting of ongoing CGM management, the one thing to note here, it's very important to understand that you can only drop this charge once monthly. Not that you can't see the patient more often than that, but you won't see a reimbursement for that claim if dropped more frequently than once monthly. So for there are going to be documentation requirements for CGM specifically. I have here for completeness sake, I do have it on the slide for you. Do be mindful that when utilizing the 2 main manufacturers' proprietary online platforms for downloading, uploading, or just getting the CGM content, much of these requirements are actually a part of that. So by printing and uploading that into the patient's chart, you'll probably satisfy a lot of these elements. But if you have to manually obtain content off of a patient's device, it is important to understand that you'll need key criteria for appropriate documentation and reimbursement. So that kind of wraps up the incident to mechanism for billing, and moving out of that and into some other unique billing and reimbursement models, we're first going to focus on annual wellness visits. Annual wellness visits are they really provide an excellent opportunity for pharmacists as they have good reimbursement rates and can create pathways into referral for clinical pharmacy services and for subsequent visits, such as chronic disease state management or comprehensive medication management or further E&M visits downstream. Annual wellness visits are not considered incident to services simply because they do have their own Medicare benefit category, but we as pharmacists do have the ability to conduct annual wellness visits as we are medical health professionals, as long as we're working under the direct supervision of a physician. There are two unique types of annual wellness visits, both the initial and subsequent visits, and each have their own G code associated with the visit, respectively. I do want to mention that there are extended time codes available as well for visits that may, the time for the visit may extend beyond the usual expected norm for that visit. So do be mindful those exist, but I don't have them on the slide for you here. I do think it's important for us to quickly review and differentiate various preventative services that may be covered by Medicare, as some pharmacists can conduct and some we cannot. I think we're all familiar with what a physical exam is. We have them throughout the duration of our life, and these are not actually covered by Medicare. But some patients will have dual eligibility or have multiple means of coverage. So you may see some patients still have physicals, but we as pharmacists cannot conduct a physical exam. The Welcome to Medicare visit is that entry-level preventative visit for our Medicare Part B beneficiaries. You, once enrolled into Medicare Part B, within that first 12 months of enrollment, you qualify for a Welcome to Medicare visit. And this is a one-time visit. We as pharmacists also do not have the ability to conduct the Welcome to Medicare visits, but really where we come into play are for the initial and subsequent annual wellness visits. The annual wellness visits, you qualify as a Medicare Part B beneficiary as long as it's been greater than 12 months since obtaining Part B, and as long as it's been greater than a year since having the Welcome to Medicare visit completed. So if you have a Part B patient that it's day 364 of, they're a couple days before the year limit for their Welcome to Medicare visit, you do have to wait a full 12 months before you can actually conduct that initial annual wellness visit. Next slide, please. Thanks. And then I do have some nuances between the two types of annual wellness visits. We could talk for a very long time about annual wellness visits and some of the nuances, but just here to kind of highlight some of the differences. They're actually very similar. What I did really want to touch on, though, is on the right-hand column, the limitations. Again, that initial annual wellness visit is covered by Medicare only one time after the patient has been eligible with Medicare Part B for at least 12 months, so after that Welcome to Medicare enrollment phase. But I also want to note that the first wellness visit, regardless of age, is the initial wellness visit. I think that hangs people up a lot of times, right? So if you have got a patient that's 85 years old and they've never had a wellness visit, it's still their initial wellness visit. All visits after that are the subsequent annual wellness visit, as long as it's been greater than 12 months from the prior visit. So with that really wraps up my portion of the Incident to billing. I'm going to hand it back off to Dr. Wesling to talk about other unique billing and reimbursement models and start with chronic care management.
Thanks, Ryan. So we're going to jump in on the chronic care management as a possible billing and reimbursement model. This is a specific Medicare Part B benefit that CMS set up after they've identified back a few years ago that a large portion of their beneficiaries had 2 or more chronic conditions, with 99% of Medicare spending targeted at the care and management of those conditions. So CMS really sought to optimize the management of chronic disease states and develop this chronic care management model. So CCM is an atypical incident to service, and it does allow for licensed pharmacists to perform and bill for CCM services for either face-to-face or non-face-to-face care as clinical staff, utilizing and applying those typical incident to billing rules. However, uniquely, this supervision would be general and would be under the general supervision of our qualified healthcare provider. Your CCM patient may be, or your Medicare Part B patient may be eligible upon assessment by your qualified provider. Your qualified provider will be required to enroll that patient after they'd identified that the patient has 2 or more chronic conditions, and those chronic conditions are expected to last at least 12 months or until the patient's death. And the identified chronic conditions place the patient at significant risk of death, acute exacerbation, or functional decline. So like I mentioned, there is a requirement for the patient to be enrolled into CCM, and this has to be done by the qualified healthcare professional. And so oftentimes CCM enrollment will occur at an annual wellness visit or a typical evaluation and management visit. And at that time, if the patient is eligible, the provider must receive consent, and this does not require written consent, but verbal consent would be sufficient. They have to identify to the patient that only one practitioner can furnish CCM. So they can't be going to multiple providers and enrolling in CCM. We can really only have one practitioner furnishing such services. And the patient has to be advised that they are allowed to discontinue services at any time, and that there may be some costs associated. So some sort of cost sharing that they need to be notified of at the time of enrollment. I put on here, if not duly eligible. So what that means is that if your patient has a secondary insurance such as state Medicaid would pick up the co-payment that may be generated. And lastly, during that CCM enrollment by the billing practitioner, there has to be a comprehensive care plan developed and provided to the patient. Now, the CCM plan of care defines the problem list for the patient. It could be expected outcomes and prognosis, measurable treatment goals, and all of this care plan would be provided to the patient as well as other members who may participate, including that clinical staff. In addition to advanced consent, the comprehensive care plan being developed, the service must provide an opportunity for continuity of care, enhancement of communication. So maybe we're providing alternative routes for communication via a patient website that they can communicate accordingly, or they can call in for any needs through a call center. And we have to provide them with 24 access to address any urgent needs. So within my clinical practice, we qualify this with an on-call service where there's someone assigned to pick up any urgent calls that may be coming in. At the time of CCM enrollment, I do want to note here that not only will the billing provider submit their respective CPT codes for the visit itself, there is an add-on code, the G0506, that is specific to CCM enrollment that can be simultaneously submitted. Now, for clinical staff, the billing and reimbursement on our end is going to be cumulative for the entire month and is billed only once a month by a single billing provider. That code that's selected is going to be based on time spent as well as the decision-making complexity. And you can see here on the slide, I've split it where we've identified 99490 as non-complex, whereas those that are spending at least 60 minutes and have some sort of complexity to the decision-making, we can get a higher level code of 99487. I wanted to share a little bit of an example. We've been at my HSC Health Clinic really implementing CCM services. We have a very high complex patient population with very low health literacy, a lot of chronic conditions. So we've engaged this throughout our family medicine clinic, first identifying the eligible patient. And we've really sought to target those with dual eligibility just from a cost perspective. However, again, Medicare Part B only patients are eligible. We will enroll them by the billing provider during one of those visits with the billing provider, and at which point that comprehensive care plan is developed and that G0506 code is submitted. Uniquely at the time of the enrollment and this code being submitted, we have an automatic tasking process where the medical assistant, our optometrist, our social worker, and the clinical pharmacist are alerted to that patient's enrollment, igniting our participation in their care. Specific to clinical pharmacy, we actually have a chart review process where we will review the patient's medical records for any medication related problems. Maybe we're doing assessment on the on their chronic conditions relative to their therapy goals. And for that chart review, we are submitting time on task, and we qualify or identify our time spent based on a dummy code of a CCMRX. I also want to note that this chart review will provide a step into or a referral process into the pharmacy team for comprehensive medication management, where we'll have an opportunity to optimize that medication regimen. But every subsequent touch that we have with this patient, now that they're CCM enrolled, can be generated for time on task. I won't spend too much time on this slide, but I do want to note that there is a new service that has been proposed by CMS. It's the Principal Care Management Service, and this service really seeks to enroll those patients who have a single serious and high-risk chronic condition. And CMS really qualifies this condition as one that's expected to last between 3 months and 1 year, or until the death of the patient. And it often has led or may lead to recent hospitalizations, place the patient at significant risk for death, functional decline. And they note that the complexity of this chronic condition cannot be managed effectively by their primary care provider, but requires some additional specialized practitioner to be involved. However, CMS does not have a great delineation stating that primary care cannot be involved. They really are intending for this to be at the source of a specialist. Similar to CCM, the PCM billing codes can be, must be submitted by a billing practitioner, and the patient must be enrolled by that same billing provider, at which point they obtain informed consent and they establish a disease-based care plan for the patient. The HCPCS codes defined are time-based, so 30 minutes of time spent with a physician will generate a G2064 code, while clinical staff time, again, a 30-minute time spent, will generate a G2065. And lastly, we'll spend our last few minutes together talking about transitional care management as another billing and reimbursement model that may be accessible for pharmacists to engage. So transitional care management follows again from CMS typical incident 2 rules that engage a beneficiary who is moving from the inpatient to the community setting. And there are specific terms associated with what locations will qualify as inpatient, and then same with community setting. They often are going to go home, but assisted living facilities would also qualify. Now, this is a bundled service. So the face-to-face care spent by maybe you as the pharmacist or the physician will be accumulated with that time spent in non-face-to-face care. And the required elements will be that the patient is contacted via some interactive communication, maybe text, email, phone call, within 2 business days of discharge. And this could be a licensed clinical staff member. So maybe that's a pharmacist, maybe that's a care coordinator or a nurse within your institution. Pharmacists can engage in between these 2 elements in non-face-to-face care, maybe providing patient education, conducting a medication reconciliation, or preparing recommendations for medication management in time for this face-to-face visit that should be established with the physician or qualified non-physician professional. Now, you can still participate as a pharmacist in this face-to-face visit and conduct specific services if that is the need of the clinic that you serve. Now, they do identify 2 different supervision requirements. So at the time that you're conducting any non-face-to-face service, that can be under general supervision, while any face-to-face care should be in direct supervision with your qualified healthcare provider. As it is a bundled service that gets submitted at the time of that face-to-face visit or within 30 days of discharge, there has to be distinct documentation that notes when the patient was discharged from the facility, the date that that patient was contacted or the caregiver was contacted within 48 hours from discharge, and the date that the patient conducted their face-to-face visit with the billing provider. The last piece is that we identify complexity of the medical decision-making. And this piece really defines what billing code we're going to be able to submit and at what time frame. So if we have a patient who qualifies as moderate complexity, the face-to-face visit must occur within 14 days of the discharge, and you would be eligible for providing that 99495 code. If the patient is defined as being high complexity, that would be a face-to-face visit within 7 days of discharge and the related 99496 code. There is some distinct rules around how to identify the complexity of that decision-making. And some considerations are the number of possible diagnoses or management options that have to be considered, the amount or complexity of the medical records, diagnostic tests, and other information that you have to obtain, review, and analyze post-discharge, and the risk of the complications, morbidity, mortality that may come with the comorbidities that led to inpatient hospitalization to begin with. And so with that, we are going to display a example TCM workflow. This is not the only workflow that can be considered, but you can see that this workflow defines the pharmacist integrated between that interactive call and that face-to-face visit. What is nice is that CMS has allowed for some CPT codes in addition to the TCM service to be billed. So for example, if your patient is CCM enrolled and you're conducting this non-face-to-face service, you can subsequently bill for time on task for that patient for those CCM, for that CCM enrollment status. So something to keep in mind. And then you can see that face-to-face visit will be conducted and the resulting CPT code submitted. So that brings us to the end of our discussion today. We've discussed a lot of different billing and reimbursement models during our time together, but I do want to note that many of the services we're talking about all speak to, in some capacity, optimizing medications and ensuring optimal clinical outcomes. And this will be a great opportunity for you guys to discuss maybe comprehensive medication management within your pharmacy service as well. And so in addition to the information we provided verbally and via these slides, we want to also give you some resources as you start in your billable service ventures. Specifically, I want to call out the physician fee schedule lookup, and that really is going to speak to what the reimbursement or fees may be associated with the service code submitted. You can find your Medicare administrative contractor and their related websites through this website. And then a really awesome resource that I use quite a bit is the Medicare Learning Network. They really utilize this to speak to the practitioners and allow for us to understand the expectations with services being developed or implemented within the clinical space. And they have an e-newsletter that comes out quite a bit that alerts you to changes or new services that may be coming up. So I really like this. It makes it very easy and understandable. And then obviously we have a lot of pharmacy organization tools that you can refer to from an advocacy, billing, and payment standpoint specific to the profession of pharmacy. So with that, we have about 5 minutes left. We are happy to take any questions, and we appreciate your time as we lay the foundation to billing and reimbursement of pharmacist clinical services.
I do see some questions in the chat box. So maybe field those first, if that's okay.
Yes. And I saw a couple come through that said, will it be recorded? I apologize that we didn't get there first, but yes, this is recorded and we will be sharing the link for it as well as the slide deck for your reference.
Excellent. My audio mishap will be recorded forever. Wonderful. So I see some CGM questions. The first question is, can the CGM 95251 code be billed virtual if virtual care is provided? So 95251 does not need to be there doesn't need to be a face-to-face visit with the patient. Analysis can be obtained remotely. Yeah, yes, would be the answer that I would pose there. And then it looks like Jonathan had asked, our compliance department has said we can't bill 95251 incident 2. Does anyone have any evidence contrary? I don't have any strict evidence, but our method for navigating this has been really pointing back to all the check boxes for incident 2 requirements, as long as those requirements are being met, and that we're following our own state scope of practice, which CGM interpretation is well within the scope of practice for the state in which I reside, at least in practice. And it looks like there are some other issues that the other comment here was about that issue. So it might be worthwhile for us to maybe explore that a little bit further in some of our roundtables, maybe moving forward. I'm not sure, but definitely a good opportunity, since it seems like that's a common thread here. And then it looks like, Megan, there's a question on TCM for you there.
And the question is face-to-face for TCM allowed via telehealth at this time? I will get back to you on this question, Kristen. I am not present. I do not currently practice for TCM. I've had historically, and with the current COVID-19 regulations, I am not sure that that has pushed us over to being allowed to bill telehealth for those face-to-face care. If anyone else has any perspective, feel free to jump in and enlighten us. But as far as I know, I do not have a distinct answer. I apologize. Other questions? We're going to wrap out here in about 2 minutes. Yes, this will be available for offline viewing. I believe we will be converting it into a YouTube link, and we'll be sending that out along with sharing those slides. Okay, I'm going to go ahead and stop recording. Dr. Wargo, it looks like there was a question. Does incident 2 apply to PMPM type of setting, like a bundled payment setting?
Incident 2 applied to PM bundled payment setting. I guess I'm not quite understanding the question, actually. I mean, would Michelle, would you be able to elaborate? Are we able to have participants unmute, or?
Yes, we should be able to. I can